Right.
The other one is called Darkness. Yeah, it's a form of.
Can everybody hear me okay? Yeah. Okay, I'm a pretty loud talker, so I don't think a microphone will be necessary, but first I just want to thank everybody for coming. The PAL organization is very near and dear to my heart. I served on the board for a couple years. The topic that we're going to cover today is about navigating, ethical standards in treatment. I'm a big data guy, and so I really am a huge proponent of organizations such as addiction treatment centers capturing data and using it to improve their quality to best serve the individuals that are coming through their programs. So just to give a little bit of a brief background on myself, my name is Parker Smith. I'm the founder and CEO of a company called Simplifiance. We help treatment centers with everything from compliance, day-to-day operations, quality improvement. We have both software and services that we deliver to these types of organizations. And I started my career in behavioral health care over 12 years ago. When I was in undergraduate school, a handful of my closest friends, unfortunately, all started using drugs and alcohol and began abusing them. I was a student athlete at the time, really struggled to know and understand what was happening, what they were going through, how to help them. I was scared about, ousting them to people in the school or their parents. But I was also watching them get very, very sick. And after one of those friends overdosed and passed away, I made a commitment to work in this industry and initially started as a counselor. So I went to a school in Denver, Colorado, a small liberal arts college called Regis University, really bought into the concept of living a life in service of others. And shortly after graduating, started to pursue what's called a certification in addiction specialty. Each state has their own version. I think it's called the LCDC or something along those lines here in Arizona. But I started my career as a counselor. I worked at organizations that had court-mandated classes, and so I ran some of those groups. I worked with individuals. And then about 6 months after college, I got in with a startup addiction treatment center in Boulder, Colorado called North Star Transitions, and was the third employee within that organization. At the time, we had a recovery coaching model where we would work with young people who were struggling with mental health and substance abuse issues. And that organization grew quite rapidly over the course of 4 years. We went from 3 employees to 75. We went from a recovery coaching model with no locations to a full continuum of care, withdrawal management, residential services, outpatient, sober living. And by the time that I left in 2018, as the director of operations, we had about 1,000 patients per year that we were seeing, about 75 employees, and about 10 total locations. So I lived the clinical side and the counseling side, and then I moved quickly into operations and business administration. And we were a great program. We, were very ethical in our approach. We had a really great founder who had his own story of recovery. But what I realized very quickly coming into the industry and having gone to a few conferences is that not all of these programs are operating ethically and with patients' safety and their healing journey as the top priority. And it motivated me, putting a little bit of a pit in my stomach and a nausea about generally accepted standards in our industry and really wanting to do something about that. And so I instituted a lot of processes and systems around quality improvement, safety, and ethical care within the organization that I worked at. And then eventually took that skill set almost exactly 6 years to the day and started my own business, Simplifiance, initially as a consulting firm, helping organizations navigate compliance, quality improvement, state licensing, accreditation, all the things that I had managed successfully at North Star. And then we eventually developed a software for organizations to streamline, stay on top of all these things, and really make all the box checking as easy as possible so that they could pull meaningful data out of that information and focus on client care. So in a recent study done by the National Council of Mental Health and Wellbeing, they surveyed about 15,000 mental health workers. 68% of them shared that administrative work takes away from their ability to provide quality care. That's one of the main problems that we seek to solve, is giving more time back to the providers to be with the patients. Our mission is to raise the standard of safety and quality in behavioral health care, and that's what we do and the direction that we row in together every day. So enough about me. Let's talk a little bit about the industry. Addiction and mental health issues are clearly some of the most prevalent and relevant challenges that we have as a society. So COVID seriously exacerbated the issue, although some of the infectious diseases have subsided to some degree, the problem has not. Fortunately, there has been some destigmatization, especially in the last 5 to 10 years, and so people are more open to treatment, they're more open to recovery. I recently heard from someone that Gen Z is actually one of the most sober generations, and there's a huge push in the younger generation to be in recovery or to be sober and to live kind of straight edge. And so as our society develops and as more information and education comes into our culture, it's a really positive time for us as a wider healthcare provider collective to really take advantage of this time and continue to promote integrated behavioral health services within the overall healthcare network that all of us as human beings inevitably need. So the topics of exploration today is we're going to talk specifically about what the intended role of treatment is in the recovery process. We're also going to talk about how to evaluate objectively treatment center quality, knowing that there is a wide range and variability within the quality of these types of programs. So the way that I like to frame almost anything, especially within my own business and with my team, is that we're full in life of both opportunities and challenges. And so the opportunity and the challenge that exists within the topic of conversation today is, one, we have an opportunity to find the right treatment setting for ourselves and for our loved ones because there are more available than there's ever been. However, the challenge that we're also posed with is there's such variability in quality and in cost, it can be very overwhelming, and the decision that we make with our loved ones or for ourselves has a very significant impact on our human experience. So some of the key objectives that I want us to touch today and information that I want you to leave with coming out of this is understanding what treatment options are available. We're going to explore a little bit about what the continuum of care is and where, at what stages in people's journey might be appropriate for different treatment settings. We're going to further define specific data points for objectively measuring quality. There have been a lot of historical excuses for not doing that, and I'm here to end that and put some objective facts to the ways that we can measure quality. The third key objective is to empower individuals and families, as well as treatment providers, to select the right treatment setting for themselves and loved ones, or at least have a little bit more information to make those decisions independently. This guy might have died, so I'm just going to go through this way. So what are some of the reasons that someone would need treatment? These are really my definitions. There's a lot of different schools of thought. There's a wide variability in treatment philosophies, but the three main points that I think are important for people to understand is that someone would go to treatment, whether it's because they have a broken arm or because they're having a mental illness or they're having undesirable symptoms that are causing mental and or physical distress. Personally, I believe that it's very, very difficult to have a strong mental health if you're not physically healthy. It just becomes a lot more challenging, and so both are very much intertwined in that we are, very complex people. There's a lot that's going on not only in our brain chemically, but in our mind and our bodies, and these are all tied together. And so the reason that you would go seek treatment is to reduce those undesirable physical or mental symptoms that you're experiencing. The second reason that I think that it's really important for some people to go to treatment is to start to treat some of the underlying problems of why they're having and exhibiting some or maybe exhibiting addictive behaviors. So I'm not the type of person that will ever label someone as an addict or not an addict. People have addictive behaviors at times, and there's various reasons why that could be. Some may feel like they do have a disease of addiction, and that that could be a a reason why. Some people have things like trauma or adverse child experiences that may be causing a self-medicating cycle for an individual. And so going to treatment to try to understand what some of those underlying challenges may be, or those underlying reasons as to why the individual is exhibiting these addictive behaviors, is, I think, a very important part of why someone would go to treatment. And then third, and most notably in my opinion, is to build recovery capital skills. And so, just like some sort of long-term chronic disease or some sort of long-term, physical or mental approach to health, you have to be able to build skills, and it has to come from you as an individual. You can have external sources that are motivating you to get treatment or to stay sober, but at the end of the day, it has to be up to the individual. And for the individual to be successful long-term, they have to be able to build skills to be able to self-manage. They have to be able to connect with some sort of community that can help support them. And we'll dive in a little bit deeper to what recovery capital skills mean. And we'll also dive into what some individuals and organizations might describe as a successful treatment episode. To me, a successful treatment episode is when someone is able to go through a recovery care type of program and build skills and access to community, so that if they fall into a trap again, or they relapse, or they come across difficult times, that they don't have to go back to treatment. Or that might not be the only alternative for them, that they can return to a community, they can return to a process, they can return to a plan, and they can use those recovery capital skills that they've developed during the course of treatment and beyond. So I'm going to describe just at a high level what the American Society of Addiction Medicine is. I'm sure most of the people, if not all of you in this room, understand that they are the academic authority for the way that we help to define criteria for different levels of substance abuse and addiction challenges. And every state which regulates these types of facilities adopts some form or fashion the ASAM criteria as it relates to things like assessment, treatment planning, progress documentation, etc. And so the way that ASAM breaks down an individual in the way that they need to be assessed for the appropriate applicability for care or the stage in recovery that they may be at really does encompass the whole person. So getting back to my point about the fact that we are complex human beings, there's a lot of different things that are external and internal that are affecting our decisions and our mental health. And so I'm going to break down the 6 specific dimensions of the ASAM specifically. So the first one, when someone's looking at potentially treatment, or a loved one is assessing their family member who's struggling, is what is their acute level of intoxication or withdrawal potential? This is a very, very serious part of the process, because we're trying to understand the volume of how much someone has been using, the substances that they've been using, and the duration of time that they've been using for. So especially with alcohol and benzodiazepines such as Xanax, there's a high withdrawal potential that could lead to death. And so it's very, very important, first and foremost, that we understand the level of intoxication, the volume of use, the frequency of use, and how recent that's been, because if some people have been doing it for a long time at a high volume, they could be at a risk of overdose and death. And so that's the first of the 6 ASAM dimensions for us to be able to understand about the individual who's struggling. The second is biomedical conditions or complications. Again, back to the whole person. We have genetics, we have biology, we have different routines, we have different bodies. We're all different. Some people have comorbidities, some people have previous medical complications. Those are important to know as it relates to someone's active use in addiction. The third is emotional, behavioral, or cognitive conditions or complications. Maybe there was recent trauma, maybe there was a recent death in the family, maybe there's a divorce or a loss of a job. There are a number of different factors that influence our emotional and behavioral and cognitive health and well-being. And so measuring and understanding that on the front end of deciding whether treatment is a good option or not, or what level of care is the right option, is extremely important to understand the headspace emotionally, cognitively that the individual is in. The fourth is their readiness to change. Again, back to my concept that it has to come down to the individual and their desire internally to get healthy. There are multiple different stages on the readiness to change wheel, is what we call it. And people can bounce around within that. So the first one is pre-contemplative. Someone, in terms of their readiness to change, is thinking about it, they're considering it, but it's maybe a little bit of an afterthought at times. They kind of have this knowingness and this feeling that something should change, but they're not ready to take action. The next stage is contemplative. So they've thought about it, they've considered it, they're starting to contemplate making what's the next step, which is a plan, the planning stage. They're planning for interventions, they're planning for changes. They're thinking about what can they do and put pencil to paper on a plan to be able to go and get healthy. The next stage in the readiness to change is taking action. So actualizing on the plan, taking next steps, whether it be finding treatment, connecting to 12 steps, sharing with their family, starting with that. The next phase on the readiness to change, which is where we'd love to see people at, is maintenance. They have a program that they're working. They have a community that they're a part of. They understand that it takes ongoing work to be able to stay healthy. And then the next phase, which many people hit at some point, is relapse. That can be part of the process in the readiness of change cycle for people. And sometimes it takes multiple times of going into recovery or seeking treatment to really have the proper motivation, and then that person can jump right back into planning or right back into action. And so if someone relapses, that doesn't mean that all has been lost, especially if they've been working on building some recovery capital skills. Those don't go away, even if someone does fall back into some old habits. The fifth dimension is their relapse, continued use, or continued problem potential. So this kind of goes back to the frequency and the duration and what they've been using for how long. Maybe they used earlier that day, maybe it's been a week, maybe it's been a month. This is a really important factor as it relates to someone's recovery journey, is what does it look like in the past, and what kind of patterns might we see or expect as a result of that, and how does that tie into the appropriate level of care or care setting that they're going into. We want to avoid putting people back into a situation that hasn't worked multiple times, and unfortunately that happens too often. The sixth, which I think is extremely notable, is the recovery environment. Fortunately, the state of Arizona is finally starting to move forward in some regards as it relates to seeing housing as a healthcare issue, as a medical component, as part of their quality of life and well-being. Where we live, where we habitate, has such an important impact on every part of who we are, physically, mentally, culturally, spiritually. If you're in a home where people are using, or if it's being promoted, that can be very risky for an individual who's in early recovery and coming out of treatment. Going back into an unstable recovery environment can be very detrimental. So that's something that's important to look at on the front end as someone's evaluating recovery and treatment, but also post-discharge as well. So what I'm going to break down next for everybody, and many of you may understand clearly the different levels of care on the continuum, and we'll start kind of bottom and move up based on the level of acuity of symptoms that the individual's having. So that first ASAM dimension was the acute level of intoxication or the withdrawal potential. As I mentioned, if someone has been using a lot of alcohol or a lot of benzodiazepines and even opiates, stimulants, things like that, it's probably good to consider an inpatient hospital setting. There's doctors, there's nurses, there's medications. Someone might go into a post-acute withdrawal symptom episode and need to get rushed into the emergency room. So if someone has been using an enormous amount of substances, especially alcohol and benzodiazepines, this is a level of care that someone would want to look to first as a stabilizing event, typically 24 to 48 hours. Really make sure that we're focusing on life safety, which is, of course, the first step in long-term recovery. The level of care that is a step down that we see a lot in addiction treatment centers, locally, nationally, is what's called ASAM 3.7 withdrawal management, which is medically managed detoxification, where there's full-time nursing staff, there's a physician on call, there might not be a full-time MD at the facility 24/7, but they're available, and the nursing team as well as the clinical team is driving the care and helping that individual move towards that next stage in their recovery journey, which is planning out what those next steps will be. So typically, this is a 2 to 7 day level of care that they're going to stay at, and is really about stabilization and planning the next step. Level 5, which is kind of confusing, it doesn't have the withdrawal management at the end, but it is that same level, 3.7. It's a highly structured environment where the individual is residing, They're being fed, they're being driven through kind of a daily schedule that's set for them that involves some movement, a lot of clinical interventions and group therapy. Typically this is in a bit of a smaller setting, although some larger institutions have this level of care. Typically an inpatient stay is going to be anywhere between maybe 10 and 14 days, typically no more than 30 days at the very most. So as we step down, there are 3 additional levels of residential level of care. So in the residential level of care, typically there's not full-time nursing, there's overnight allied health professionals, behavioral health techs is one of the words used to describe frontline workers that are in these types of facilities. Again, they have a daily structured schedule, especially at the 3.5 level, typically about 20 hours of clinical programming per week. They're seeing a therapist, they've seen someone for medication management. And they're still in that stabilization and planning process. Their day is, designed for them, and they're following a schedule. Oftentimes, these facilities are taking them to 12-step meetings or taking them into the community for some sort of engagement and initiating the process of re-engagement into society and into community. The lower levels of residential are typically just less and less clinical programming and longer stays. So 3.3 may be more like 90 days to 6 months or maybe even a year. 3.1 might be multiple years where someone is really stable in this, peer environment where everybody's committed to, recovery and that there's rules in place, but there's not a whole lot of oversight. But it hits that 6th dimension that I mentioned on ASAM, that it's a strong, positive recovery environment, which is such an important and crucial part of the process. So as we step down to ASAM 2.5, this is probably the most confusing nomenclature in behavioral healthcare language. It's called partial hospitalization programming. The reason it's confusing is that it's typically never done at a hospital. It's the highest level of outpatient care, typically 25 to 30 hours per week. Someone's being seen. They're typically seeing someone for medication management, like a psychiatrist. They're seeing an individual therapist one-on-one, but they're coming to outpatient treatment as if it's a full-time job. So they might not be ready to go get employment yet. They might not be ready to maybe go back in school or pursue the next steps of their life. They're maybe living at home, or they're living in a sober living. Oftentimes sober living and PHP and IOP level of care are integrated under one program. So they're out in the world, they're having more agency and more freedom over their own decisions, but they're still in a highly structured treatment episode where they're going Monday through Friday, typically 9 a.m. to 3:30 p.m. or so. And they're starting to build community. They're starting to plan for this next step down towards more community freedom and engagement. One of, if not the most popular levels of care as we step down is intensive outpatient, or you may hear that word IOP. We'll do a little Q&A at the end if you're all right with that.
Just a quick question, would like a methadone clinic be part of that?
Yeah, so that would actually be in a different type of classification of treatment called harm reduction. So that's a non-abstinence-based treatment where there's an attempt to reduce the amount of use or the dangers of use of illicit substances using, other prescribed medications like methadone or Suboxone. So we're not really covering those harm reduction models today. So level 2.1 intensive outpatient is a really good step down for people to stay heavily engaged with treatment, but re-enter society, whether it be in the workforce, whether it be back in school, whatever that looks like for the individual. Typically, this is about 10 hours of treatment per week, 2 to 3 hour 3 times per week group therapy sessions. A ton of research has been validated that group therapy is an extremely effective modality for individuals in the recovery process, as it is for families, and another reason why I'm such a huge cheerleader for PAL and what they do. So intensive outpatient, oftentimes they'll offer these groups in the evening so people can gain full-time employment again. And we see payers such as insurance companies and Medicaid, Medicare services really wanting to see a fairly quick step down from the higher levels of care to intensive outpatient, because reintegration in community is really a big part of long-term health and recovery. The last level of care is just level 1 outpatient. This is a minimum of 1 touch per month. Oftentimes looks like once per week, maybe seeing an individual therapy one-on-one, maybe attending like one 90-minute outpatient group per week. So hopefully that's not overly repetitive for too many people, but I like to kind of set the stage as in terms of what the continuum of care looks like, how that relates to the 6 dimensions of the ASAM. And the next step of our presentation is going to really start to dive deeper inside these treatment centers, and back to my point about being a data nerd, how we can actually objectively define quality and effectiveness of programming, which the historical reasons for not being able to collect that no longer exist. Some of the reasons why historically treatment has not been very measurable is because everyone is so different and everybody shows up differently while they're in treatment, and then everyone also has a completely different experience after treatment. And so the best ways in the past that people were able to try to track the successful outcomes or the rate of success as part of their program is to call people every 30, 60, 90 days after they leave treatment. How are you doing? How are you feeling? A lot of people don't pick up the phone. Maybe some do. Maybe some of these places were only making these calls to try to re-enter some of these individuals as well. And so that was kind of the old way of doing it. Part of the complication is that it's not black and white. If you break your arm and you go to see a provider and they give you a cast and they tell you in 3 weeks, you can take it off, and you come back and you have that session, that's a very clear, successful outcome. It's very black and white in terms of having a medical issue, having some sort of medical intervention, and then getting to a desired outcome. Behavioral health and recovery is a long-term, lifelong process that cannot be measured in one acute episode. It's over the course of an entire amount of time. And so what are some of the ways that we can measure the effectiveness of a clinical program or a treatment center? Number one, it comes down to self-reported symptomatic data from the individual that received the care. And so over the last 10 plus years now, there has been over 70, probably 100 now, of these validated instruments or assessment tools that are as simple as sometimes 10 or even 20 question assessments or surveys that the individual who's receiving care takes, either on admission or pre-admission, and then every week or every month throughout the treatment process. So the reason that this is so important is that we can do our best as professionals to describe whether or not someone has made progress. But ultimately, the individual being responsible and needing the agency to make their own decisions about recovery and their long-term health and well-being also need to be able to see objectively, being asked these questions, whether or not they're feeling better. And what does feeling better look like? Well, it's different for every chief complaint or every different type of reason that someone might enter care, but I provided a couple of examples of these validated instruments. The Brief Addiction Monitor is one that's very specific to addiction treatment. The PHQ-9 is more specific to mental health care, but it gives the individual the ability to reflect through answering some very easy questions that can be administered through a piece of paper, through a text message survey, or through some sort of tool like that, very inexpensive, where they're at as it relates to where they were a week ago or a month ago. So something that's measurable is, on a scale of 1 to 10, I have X cravings. My desire to use is a 9 out of 10. Well, clearly that person is in an acute crisis, feeling like their main option that they'd like to pursue is continued use. However, they're showing up in treatment. When we go to actually build a collaborative treatment plan with the individual, we can use these validated assessments to be able to make the treatment plan goals and objectives measurable as they relate to the individual's self-reported symptomatic data. So follow with me here. If we're giving someone the opportunity to share in a really easy for them to understand and answer capacity, reflect that data back to them and say, what would you feel like if in 90 days your cravings went from a 9 out of 10 to a 6 out of 10? And what kinds of interventions can we do together here and there in the therapeutic process, but also in your recovery community, to measurably reduce that over time? And so to me, clinical and treatment center effectiveness comes down to measurable results of individuals self-reporting that their undesirable symptoms are reducing or their desirable and quality of life experiences are increasing. So there are ways to measure the effectiveness of the people that are going through programs. And then furthermore, that data actually helps the organization identify who the right types of individuals are for them. And that is ultimately the circular, best practice motion of continuity of care, is that treatment centers that have, historical data that's self-reported from their individuals receiving the care can help to guide their admission criteria, their marketing efforts, where they're doing outreach, and speak from confidence when they're talking to families and individuals seeking care that they have some data to back up why it's the right place for that person to go. So one of the other ways that we can measure a treatment center's quality, which is very much not talked about, except for me, I talk about it all the time, is safety. So the individual safety, there's a reason why we need to do fire drills. There's a reason why we need to do emergency preparedness drills. There's data that we can collect coming out of these exercises. Same with infection prevention and control. There are all kinds of accreditation standards that tie back to best practices for collecting data around infectious diseases and how to continue to mitigate those risks. A lot of people didn't take this seriously until COVID hit. All these treatment centers needed to stay open because the risk of people dying from COVID was less of them dying from their addiction. And so these places stayed open. They didn't get a lot of PPE. They weren't prioritized in terms of emergency medical equipment. But the programs that really bought into those standards around infection prevention and control and had the data and had the measures and they had the materials to be able to promote a safe environment. Oftentimes treatment's expensive. You're coming in not feeling well. Nobody wants to get sick. If people are getting sick in this type of facility, that's not quality. There are measures that they can put in place. There's data that they can collect. Same goes for training and education of the staff. This is a very demanding job. I give the ultimate amount of respect for anyone that has ever worked in treatment at any level, because it's a very, very difficult setting to work in. It's very mentally distressful. There's a lot of variable energies. There's a lot of different curveballs that you get on a regular basis. And a lot of these places do not properly train or educate their staff on how to handle those situations, on how to de-escalate, on how to understand through a trauma-informed care lens or a culturally competent lens about those individuals that are coming into care. And so these are all measurable parts of a program. And I'd like to give a really good example of a program that we worked with years ago up in Estes Park, Colorado, Harmony Foundation, been around for 60 plus years. And they had such an enormous amount of emergency preparedness data, practice drills, when there was some terrible wildfires in the area, and they had to evacuate this enormous campus with over 50 patients. They were able to successfully transition into a large hotel 2 hours away, and none of the treatment was disrupted at all. All of the clients were able to continue to be served, and it was because they had that preparation, they had that commitment to safety, and they had the data that had prepared them to be able to execute in that regards. So diving a little bit deeper on the outcome side, you hear this buzz, outcomes. Well, what's a positive outcome? And some people are still saying, oh, well, we don't know. Well, one of the ways that we can figure out if people are having positive outcomes is by asking them using these surveys, using digital tools. You can definitely use a stack of papers and get out a calculator and aggregate it all and figure that out, but there are very, very low-cost options for ways that you can engage with your patients prior to admission, during the course of treatment, and long-term in a way that isn't too time-consuming for them or isn't overly laborious and can be accessible to them on their phone, which all of us, are pretty reactive to. And so, spending 5 minutes to answer a text message survey is a great way to engage someone and get important validated data about how they're actually doing as it relates to their overall health and the goals that they set out for themselves in care. Performance and quality improvement data is all encompassing. So oftentimes we think as treatment as clinical and medical, and that's what people come to do. But as I had mentioned in this full continuum of care and some of these other levels, there's a lot of downtime. There's a lot of community time. There's a lot of social time. And there's a lot of different ways that organizations can capture data from their staff and from their patients about what that experience is like. I have seen in a number of different treatment episodes, the most beneficial interaction that a patient has had is not necessarily from the psychiatrist, not necessarily from their therapist, but from the person that was working overnight when that person couldn't sleep and they were able to really open up about what was happening in their lives, and that person was maybe able to share a little bit about what their experience has been like. And so there are so many more components of care in a treatment facility just than the therapeutic interventions, and there are ways to be able to measure that through staff satisfaction and engagement surveys, employee engagement surveys, really, really low time spend ways of collecting important data that really serves as both organizational intelligence, but also for quality improvement. And so in my mind, an effective treatment center has enough data to be able to, with confidence, say, our data shows that this program of ours is right for these types of people with these conditions. That if they don't have enough data to be able to substantiate that their program is right for, this type of person, age 25 to 34, who's struggling with anxiety disorder and alcohol use disorder, moderate, is right for our program. And the people that are suffering, just like you, that have these demographics and psychographics and emotional challenges that stay for 90 days in this program, 93% of them are reporting a reduction in their cravings and an increase in their quality of life. And so if a treatment center can't tell you with validated sets of data why their program is right for which population of people, then you should ask more questions and make a strong consideration as to whether or not they are right for yourself or for a family member. So another, important kind of buzz phrase that's, becoming more and more widespread, fortunately, in our industry, is continuity of care and person-centered care. So it's now widely recognized that we are a whole person, and behavioral health care is just one piece of the puzzle of our overall health care. And so what's important is that in a person-centered care approach, we're working with the interdisciplinary team internally and externally. This can be a big challenge if you're going externally. Primary care offices, dentists, different specialists aren't the best at communicating. You have to get, privacy and confidentiality releases signed. But the more as a family or a loved one that you can push for the continuity of care with all the providers in the individual's network, the greater that you're going to be able to serve this individual and understanding that this is a well-rounded approach to their long-term success, recovery, and well-being. And so, the treatment centers can struggle with this at times. They can still try their best, but sometimes the families are going to have the most influence on the external care provider network and have an opportunity to push for that in the treatment, and should be engaged in pushing for these things and supporting in this way, without being overbearing, but still, helping to push some of these important things forward and helping the individual understand that this treatment episode is part of a lifelong journey that connects to every other part of their health and well-being, physically and mentally. A big part of person-centered care is trauma-informed care and culturally competent care. I say that one of the only safe assumptions that anyone can make in life is that any other person that you come across may and likely has some sort of trauma. Some sort of potentially an adverse child experience, some sort of dramatic episode. These live with us and stay with us. And so a lot of people that are entering into the recovery process, entering in the treatment process, are experiencing or have experienced a serious amount of trauma. And there are ways and information available and education and training available to be able to follow what's called the Hippocratic Oath that every medical professional takes, that starts with, first, do no harm. That is the number one priority in person-centered care, is that you don't harm the individual more than they already have been. You're not always going to be able to help. You're not always going to be able to help someone to make a decision for themselves or get to the next step. But what you can do is avoid harming them more. And to me, that's what trauma-informed care is recognizing that any individual that you work with may and likely has some sort of trauma, and that triggering that could be an enormous step back from them and also demotivate them from engaging in the process. Being culturally competent is also extremely important. People come from all different walks of life. They've had all different kinds of experiences. They come from different families. Sometimes that's a good thing for them, and sometimes they see that as a negative thing. And so being really responsive and not trying to just only accept anyone and everyone that has a self-perceived problem, because you might get into some situations where, you know, the cohort or the milieu of people aren't supporting one another because they have conflicting cultural beliefs, that could also be a benefit as well, to integrate different people's cultures and to talk about that. And the regulatory authorities, such as the accrediting bodies, the licensing bodies, they want you to assess a lot of cultural data about the individual, because that's very important as it relates to their whole person, their whole being, physical and mental. Again, measurable goals in the own words of the individual. So treatment plans, which is really, that needs to be the playbook. In treatment, in recovery, I have heard way too much from too many providers like, oh, well, the treatment plan doesn't really matter as much. Like, we're just going to keep working on whatever they're challenged with that day. No. Every intervention that you do in treatment needs to tie back to a goal or an objective that's on their treatment plan. And that is something that needs to be collaboratively developed by the individual and the provider in the own words of the client. We can pretend that we know best for someone, and based on the experiences we've had and our education and how long we've worked in treatment, but that has to be on their terms and what quality of life looks like for them, and we can't project the specifics of that on them. It needs to be goals that they set and interventions that are tailored specifically towards objectives and goals that they collaboratively developed for themselves with the professional. And then post-discharge engagement, making sure that you're staying in touch, using these surveys, still making those phone calls, and engaging with them long-term. A lot of really good treatment programs have enormous alumni programs, Facebook groups. Some of them have 20,000 plus alumni, and they're all there to support each other, and they're engaging in that capacity. They're putting out content and engaging in that way. I'm not going to dive too deep into billing practices today, but I do think it's very important to note when it comes to selecting treatment, it is appropriate to ask questions about the treatment center's billing practices. What's their payer mix? Meaning, do they take Medicaid? Do they take commercial plans? Are they just self-pay? There's a myriad of payers, including counties, states, and treatment centers have a lot of different ways of billing as well. Some of them will bill out of network. They'll bill exorbitant amounts of money to the insurance companies and just hope to collect what they can. Some of them have in-network agreements with insurance companies, meaning that they have a contract. The insurance company has agreed that they can provide quality care and that they have successful outcomes. When they are in network with an insurance company, they've already had to demonstrate sets of data that validate their quality, which is noteworthy. A lot of programs will outsource their billing function, but I think that it's very important to talk about when you're asking these questions, what's your payer mix? How do you bill insurance companies? Do you work with a service provider? And help me understand what the financial roadmap looks like for me and my family, because far too much people start getting explanations of benefits that look like bills and they start paying them, and there's drug testing and all this other stuff. So getting really clear and being transparent on the billing side is super important. If they're fuzzy on that, be really careful. There are a lot of common ethical dilemmas. Again, I'm not going to go too deep into that, but it's noteworthy to recognize that that does exist, and those questions are important to ask. I also just want to share with people that treatment is not always right for everybody at any stage. It's not always going to be the best or the only long-term intervention that they have. And there are a lot of great free, no-cost resources for families and individuals. PAL is an incredible resource for families. There is no cost. You're getting training, you're getting education, you're getting peer support. It's an incredible resource to the community that's available. Smart Recovery is one, Narcotics Anonymous, Alcoholics Anonymous, the Substance Abuse and Mental Health Services Administration, which is the federal branch of our government that administrates mental health and substance abuse oversight in our country. Tons of free resources that they provide. Even the DEA has resources for recovery as well. So treatment is not always the answer. So in conclusion, treatment options vary widely in quality, in cost, in location, and so arming yourself with education and information is essential. Sometimes that there is a crisis, they need to get into treatment. Oftentimes, if it is a crisis, then that looks like a higher level of care, like inpatient detoxification. But with that said, take the time to find the right place, and I think that will ultimately bear the fruit of the best long-term outcome. The second big point that I want to hammer home is that quality of care can be measured, and any treatment program that makes that excuse and doesn't have that data, you should question. And then again, treatment is not the magic bullet, but can definitely be a valuable step in the recovery journey. So thank you very much, everybody. And we're going to stick around for about 15 minutes of Q&A for anyone that wants to ask any questions.